Welcome to Section 3 of Psychiatry. In this section, we'll be discussing childhood and early onset disorders. Let's get started. This is our psychiatry overview figure. You can see many of the childhood disorders listed in the image right here. In this video, we'll discuss several different childhood disorders that deal with learning and development. This is a nice table that provides an overview of all of the information and will be helpful for reviewing the content. We'll revisit this table periodically as we go through each disorder to help you see the big picture. All right, with this in mind, let's begin by discussing attention deficit hyperactivity disorder, or ADHD. ADHD is more commonly seen in boys and is characterized by two main groups of symptoms. One, hyperactivity and impulsivity, and two, inattention. Let's discuss the symptoms associated with these subtypes in more detail so you'll know what to look for in questions when dealing with ADHD on step 1. The first group of symptoms we'll talk about deal with hyperactivity and impulsivity. These symptoms are often noticed in childhood by teachers or caregivers and may involve descriptions of a child who has difficulty staying quiet, has a hard time staying seated, constantly fidgets, runs or climbs at inappropriate times, interrupts others, and shouts out answers when it's not their turn. An example of impulsive symptoms could involve a teenager with a history of hyperactivity and poor school performance who starts abusing alcohol at age 13. This idea is an important association, so the increased impulsivity associated with ADHD can increase the risk of developing substance use disorders. These type of symptoms dealing with hyperactivity and impulsivity generally decrease with age, although a feeling of restlessness sometimes continues into adulthood. All right, now let's discuss the second group of symptoms which deal with inattention. Children with ADHD generally have normal measures of intelligence, but can struggle in school and have developmental delays due to the disruptive effects of inattention and restlessness. So they may struggle in school despite normal intelligence. A description of a child with symptoms of inattention may include apparent difficulty listening, careless mistakes, procrastination, becoming easily distracted or is forgetful, having poor organization, or may have difficulty completing tasks. Picture a child who, while sitting at their desk, regularly gets distracted by something outside and then spends a long time daydreaming, lost in their own thoughts, and misses out on what the teacher is saying. This is a nice diagram showing the approximate prevalence distribution of the different types of ADHD. As you can see, it's possible that a child diagnosed with ADHD predominantly will have one subtype over another, but the most common scenario is that children with ADHD have elements of both subtypes, so the combined type. In other words, they're inattentive at times, but also have episodes of hyperactivity and impulsivity. To diagnose ADHD in kids under 17, there must be a pattern of behavior that is consistently positive for both types of symptoms in at least two different settings. So for example, a child may have episodes of excessive talking and interrupting others at school, and then exhibits the same behavior at home. This idea of exhibiting the symptoms in two different settings is important for the diagnosis. This behavior must be present for at least 6 months, and it must begin prior to age 12. Another important point is that the symptoms must be disproportionate for the developmental stage of the individual. This is significant because it may be normal for children under 17 to have many of the symptoms listed in the DSM criteria. For example, a child may disrupt others talking on the phone, which could be normal for a 3-year-old. However, this would be abnormal for a 16-year-old. This is why it may be possible that there has been a recent uptick in overdiagnosing ADHD. Regardless, the key feature is that the behavior must truly be excessive for the stage of development and that it is consistently interfering with normal daily functioning. A major key to all psychiatric illnesses is the element of impaired functionality, and ADHD is no exception. In the case of ADHD, the symptoms must be causing such effects as poor school performance, so academic, abnormally high levels of stress due to the inability to focus, or an inability to get along with others, so social. All right, so that was ADHD in kids. Now let's discuss ADHD in adults. First, it's important to know that the diagnostic criteria for children and adults are similar. So both adults and children have to experience multiple symptoms in 2 or more settings for a 6-month period that disrupts functionality. However, adolescents and adults over the age of 17 can be tricky to diagnose because some of the hyperactive and impulsive symptoms tend to diminish with age. For example, an adult with ADHD probably won't have as much trouble staying seated for longer periods of time, but still might talk excessively, constantly fidget, or make impulsive decisions like quitting a job without another option, or ending a relationship without fully thinking it over. On the other hand, the symptoms of inattention often persist throughout adulthood. and these can cause significant problems at work or in other settings due to difficulties creating, organizing, and completing tasks or goals. The inability to remain focused on a certain task, meet deadlines, and overlook mistakes can cause notable distress and dysfunction. One of the keys to diagnosing an adult is by obtaining a thorough history, because the hyperactive and inattentive symptoms described need to have been present since childhood, so prior to age 12. Finally, adults with ADHD are often described as irritable or anxious, and they are at an increased risk for mood disorders and substance abuse due to the effects of their illness or impulsive decisions that lead them to substance abuse. All right, let's review what we've covered so far with a question. A 24-year-old male began working at a new job 4 months ago, but was recently told that he needs to make some changes or else he will be fired. His boss is concerned because he is constantly interrupting others, frequently fidgets, and has spent company funds on useless items without proper permission. This type of behavior has been apparent since the patient was 16 years old. Does he have ADHD? Okay, from the question we learned that this patient has some hyperactive symptoms that could potentially indicate ADHD. He interrupts others, frequently fidgets, and has some impulsive behaviors such as spending company funds on useless items without proper permission. However, there are 2 key points that make ADHD unlikely. First, there was no mention of these symptoms occurring in 2 settings. Only work was mentioned. And second, this type of behavior has only been apparent since he was 16 years old. Remember, in order to diagnose ADHD in an adult, symptoms of inattention, hyperactivity, and impulsivity must have been present since before the age of 12. Therefore, this individual does not meet the diagnostic criteria for ADHD. So no, he doesn't have ADHD. Although ADHD can be comorbid with a host of other conditions, proper diagnosis should involve the exclusion of other related conditions as the primary cause of dysfunction. For example, there is a high rate of ADHD in kids with Tourette syndrome. Only about 10% of kids with ADHD also have Tourette's, but about 70% of kids with Tourette's have ADHD. So if there is a child with verbal tics and face or shoulder tics who also has a hard time in school due to the inability to focus, Tourette syndrome with ADHD should be thought of because of the presence of tics. Another frequent comorbidity are mood disorders involving anxiety or depression. Children and adults with ADHD often struggle with mood dysfunction and substance use. Also, there are frequent comorbidities with behavioral disorders, such as oppositional defiant disorder, as well as learning disorders. Therefore, identifying comorbid conditions is key to proper treatment. Treatment for ADHD involves stimulants such as methylphenidate, cognitive behavioral therapy or CBT, and alpha-2 adrenergic agonists such as atomoxetine, clonidine, and guanfacine. We'll talk more about these drugs in detail in the pharmacology section. If we return to the overview table, you can see that we've included the key points about ADHD here for your review. All right, now let's move on to discuss Tourette syndrome. Tourette syndrome is characterized by involuntary, recurrent, rapid, non-rhythmic motor and vocal tics. These are often seen in the face, head, and shoulders. Occasionally, individuals affected by Tourette syndrome make involuntarily obscene gestures, as well as outbursts of explicit language, and this is known as coprolalia. However, this only occurs in about 40% of patients. Diagnosis of Tourette syndrome involves symptoms that have persisted for at least a year. Additionally, the onset of symptoms must occur before the age of 18. Tourette syndrome is also comorbid with ADHD and OCD. Complications of Tourette syndrome include anxiety and depression, which are mood disorders. Remember Tourette syndrome with the short phrase, tic-tac-toe crap. The tic should help you remember the presence of tics. Also, the oh crap part should help you think of coprolalia, or the blurting out of obscenities, as in crap. Additionally, if you can picture a tic-tac-toe board, think of the association with OCD with the O's, and ADHD with a child that has to be constantly playing games. The treatment for Tourette syndrome is multifactorial. It includes patient and family education, CBT, Botox injections for muscle spasms, antipsychotic drugs such as haloperidol, fluphenazine, and tetrabenazine, as well as alpha-2 adrenergic agonists such as atomoxetine, clonidine, and guanfacine. These can be helpful in tic suppression, and they're also used to treat ADHD. All right, now let's move on to discuss specific learning disorder. This involves difficulty learning a specific subject during school-age years, despite over 6 months of focused help. This disorder occurs in children with otherwise normal intelligence and functionality. In other words, these kids do not have delays in all cognitive or functional aspects of their lives, as seen in children with intellectual disability. So, to diagnose a specific learning disorder, the child must have at least a 6-month history of consistently poor learning ability in one subject, and also be consistently well below average on age-appropriate tests for that subject. For children to be diagnosed with a specific learning disorder, they must not have other primary elements that better explain the whole range of their symptoms, such as vision or hearing loss, intellectual disability, or other related conditions. Therefore, proper diagnosis involves professional assessment through educational testing, hearing and vision screening, and assuring that other psychiatric illnesses or intellectual disabilities are not the root cause of the seen learning delays. For example, it is relatively common for a child with the primary diagnosis of ADHD to also have a specific learning disorder like dyslexia. Other comorbidities are also common in children with specific learning disorder, such as autism, ADHD, and behavioral disorders. Treatment involves counseling, tutoring, and after-school activities. Now let's move on to discuss intellectual disability. This is characterized by global deficits of intellectual functioning and adaptive skills. An example of impaired intellectual functioning would be difficulty with problem solving, reasoning, or a person's general ability to learn. And this can be reflected in a low IQ score. An example of an impaired adaptive skill would be difficulty reading, social communication, and bathing. The all-encompassing nature of the delays or disability is what is meant by global deficits, and this makes intellectual disability different from a specific learning disorder. For example, a child with intellectual disability will not just have difficulty learning a specific school subject. Rather, they'll have a basic inability to gain and apply knowledge in all aspects of their life. When making the diagnosis of intellectual disability, the patient must have deficits in both intellectual and adaptive functioning. They must also have daily functional impairment in a variety of settings. Treatment includes multidisciplinary support, such as family support, special education, and life skill development. Finally, we'll discuss autism spectrum disorder. Autism spectrum disorder is characterized by deficits in social interaction, as well as restricted and repetitive patterns of interests and behaviors. A good example of this would be a 5-year-old boy who avoids eye contact with others, doesn't respond to his name, but is obsessed with and knows everything about dinosaurs. Autism is seen 4 times more often in boys, and often children with autism have a larger head and brain size on examination. All right, now let's talk a bit more about how to recognize and diagnose autism spectrum disorder. Symptoms must persist during early childhood. There must be deficits in social interactions, such as a young child who consistently shows no interest in playing with others, or who doesn't attempt to communicate or understand parents and peers. Children with autism often insist on a set routine, and changes from the expected routine can cause significant distress. Another group of symptoms involves altered sensory perception. A great example of this is Temple Grandin, who is a famous animal science professor who also has autism. She describes how as a kid, she couldn't tolerate being hugged because the sensation was so overwhelming and felt like tidal waves. Similarly, scratchy clothes are often unbearable to kids with autism due to the sensory overload they cause. The final group of symptoms are restricted, repetitive, ritualized patterns of behavior or interest. These behaviors can involve stereotyped movements or sounds, like repetitive rocking back and forth or producing the same sound over and over. And as I mentioned earlier, they may have an obsessive interest with a particular subject, like dinosaurs. Okay, one last point I'd like to make is that some patients with autism spectrum disorder have increased abilities in a specific field. And when this is present, they're sometimes referred to as savants. So, for example, an adolescent could have all of the features of autism spectrum disorder, but be a genius when it comes to quantum mechanics. This is extremely rare among those with autism, but it has been reported. Treatment for autism spectrum disorder involves education and behavioral therapy, and it's important that the diagnosis is made early so that early intervention can be given, which leads to good outcomes. All right, let's wrap up this section with a question. A 10-year-old boy is brought to the office because his mother is concerned about his behavior. She says that he gets very agitated at times, and she sometimes can't control him. She says that he has recently started shouting obscenities and hitting his brother when they fight. The boy has been struggling in school for the past year, and the mom says that he has a hard time listening and following directions. The boy admits to forgetting things frequently and says that he hates school because it's boring and he doesn't understand anything. His mom says he puts off doing his math and science homework and that he frequently turns in assignments late or incomplete, but his test scores in each subject are good. He is constantly fidgeting and playing with the zipper on his jacket during the interview, but his physical exam is otherwise normal. What is the most likely diagnosis? A. Attention deficit hyperactivity disorder. B. Conduct disorder. C. Oppositional defiant disorder. D. Normal childhood behavior. Or E. Specific learning disorder. Okay, hopefully from the question stem you notice that this boy has attention deficit hyperactivity disorder. So the correct answer is A. We can deduce this because there are several key points that direct us toward ADHD. This includes difficulties in school, a history of forgetting things easily, procrastination, and constant fidgeting and playing with his clothes during the interview. He also is having problems at home and is fighting with his brother. Additionally, he has a hard time listening and following directions at home as well. In other words, he's displaying symptoms of inattention, hyperactivity, and impulsivity. This is occurring across 2 settings, so at school and at home. It's been going on for over 6 months, so a year, and he's less than 12 years old. All of these features meet the diagnostic criteria for ADHD. So again, the correct answer is A. He doesn't demonstrate the cruel acts associated with conduct disorder, so B is incorrect. He does have a bad attitude about school, but he doesn't seem to be openly defiant or vindictive like children with oppositional defiant disorder. So C is incorrect. While aspects of his behavior may be normal for an adolescent, collectively they are abnormal and are consistent with a diagnosis of ADHD. So D is incorrect. Finally, he also isn't struggling with one subject in particular like what we'd see in specific learning disorder. So E is incorrect. So again, the correct answer is A, ADHD. And with that, we've covered everything you need to know about childhood and early onset disorders.